A potassium of 7 point what? Hey guys, it's Nurse Gwenny. Let's talk about what to do when the lab calls with a critically high potassium on your patient. So a normal potassium value is 3.5 to 5.0, and we're pretty rigid about that. Your institution might have a smidgen bit off of that, but usually it's about 3.5 to 5.0. So what does it mean when there's too much? Usually we see this in our patients with renal failure because our kidneys help to regulate our electrolytes. Sometimes we see it in older adults with polypharmacy. Maybe they're on Lasix, and we know because that's a loop diuretic that also sucks potassium out of their system. We also put them on potassium to balance that. But sometimes we know patients skip their Lasix because they don't want to be up peeing all night, but they didn't know to also skip their potassium. So they come in with super high potassium values. We see it in our crush injured patients because when they have those crush injuries, it causes massive cell lysis, and we know potassium works inside the cell. It's our primary intracellular ion. So when all of those cells in their muscles get ruptured from their crush injury, or even in burn patients, it leaks all that intracellular potassium into the vasculature. And now our patients have mega high potassium values. So what happens in hyperkalemia that is the problem? So it reduces the threshold for the myocardium to experience repolarization. Well, that makes sense, right? And so that slows down the conduction through the heart. And so what are the EKG changes that you're going to see in your patients? Well, I got you some good news. They happen in the order of the cardiac cycle. So what are the first changes? What's the Sunday school? I got you some good news. They happen in the order of the cardiac cycle. So what are the first answer of hyperkalemia? Yeah, we see those peaked T waves. Well, that makes sense because what are the T waves? That's the repolarization of that cardiac cell. So of course we see mega high T waves in hyperkalemia. Okay, well, what comes after a T wave in the cardiac cycle? Yeah, it's the P wave of the next cardiac cycle. And so that's the next change that we will see. We start to get a prolonged PR interval. We start seeing a delay in the signal going from the top of the heart down to the bottom. So what comes after a P wave? Yep, your QRS complex. The next change we're going to see is a widened QRS complex, and this is where we start to see the development of blocks, and our patients will become bradycardic. So think about that if you have a patient that presents with bradycardia. And the final change that we will see as the hyperkalemia worsens is the development of a sine wave, S-I-N-E. That's the mathematical term. Remember learning sine, cosine, tangent, S-I-N-E? That is a mathematical equation for this type of line. And that's essentially what the EKG looks like. Here's an EKG of a sine wave. If you see this on your patient, you better just put those pads on them because that patient is about to code. So what do we do about it when we recognize hyperkalemia in our patients? Well, if you're working pre-hospital, we obviously cannot give the glucose and insulin to try to shift that potassium, but we don't want them going into this sine wave or potentially going into those fatal dysrhythmias. The first thing we're going to do is give calcium. What's that do to the potassium level? Absolutely nothing. What it does do is it stabilizes the cardiac membrane. Remember what we said happens to the myocardium when we have that hyperkalemia? Yeah, it lowers the threshold for the repolarization. So the heart just wants to repolarize a whole bunch. When we give the calcium, it helps to regulate those channels and counteract that antagonistic power of all of that potassium. So it's going to raise that threshold for the repolarization. So we're going to give calcium pre-hospital to try to stabilize that cardiac membrane. We can also give some albuterol, not because the patient's having breathing problems, but it does help to shift a little bit of the potassium back into the cells so it's not free floating in the vasculature. Now, this protocol came about from Europe because in Europe, they give albuterol differently than we do. We only give it nebulized here in the United States, but in Europe, they actually can give it IV. And that's where we see a pretty big shift in the potassium. But if you give a continuous albuterol treatment, you're going to be able to give it a smidgen bit of a shift in their potassium. And pre-hospital, that's pretty much all we can do is give that calcium and the albuterol. Once we get them to the hospital, we're going to pregame them with a little bit of glucose so we don't bottom their glucose out. When we push the when we push the insulin, and the insulin is the taxi cab that's going to move that potassium back into the cell, and then we're going to either diurese those patients or dialyze them to remove that excess potassium from the system. So now I hope you understand a little bit more about hyperkalemia and what to do about it and why calcium helps. I'll see you next time.